Thank you for giving us the opportunity to talk. My name is Peter Szasz. I'm the MIS Bariatric Fellow at Brigham and Women's in Boston. And our work really evaluates predicting venous thrombosis in the elective splenectomy patient. In terms of disclosures, Ali Tavakoli, the senior author, is a consultant for Medtronic and also co-founder of an Altrix Bio company, and then the other authors have no disclosures. So an elective splenectomy, defined as one not in the context of trauma or iatrogenic injury, can be performed in either a laparoscopic or open manner, often depending on the characteristics of the spleen, as well as surgeon preference. Emerging evidence is suggesting that there's shorter hospital length of stays, as well as fewer complications with the laparoscopic approach. Of the complications that do occur, venous thrombosis is one of the most common. And in terms of locations, it's quite broad, but they can occur in the upper or lower extremities as DVTs, pulmonary emboli, or thrombi in the portal or splenic veins or their tributaries. And multiple attempts have been done in the past at trying to stratify or determine the risk factors for venous thrombosis development, with really the platelet count being the most common surrogate used, although a lot of this data is outdated and not really specific to the splenectomy patient. And although the rates of venous thrombosis vary depending on the surgical approach, the literature evaluating these rates and the surgical approach really focus on more the underlying biology necessitating splenectomy rather than the techniques themselves. And those that have compared them directly really have not linked this to the platelet count. And so the objectives of our work were first to determine the overall incidence of venous thrombosis in the total splenectomy cohort and use the platelet count as a predictor of venous thrombosis incidence. And secondly, to look at the procedure-specific incidence rates, so both in the open and laparoscopic approach, and evaluate whether platelet count was more or less likely to predict venous thrombotic events. So this was a retrospective chart review of all patients who underwent an elective splenectomy at Brigham and Women's Hospital and its affiliate Faulkner Hospital between 1997 and 2008. Descriptive statistics were utilized to look at procedural types, the incidence of venous thrombosis, and patient demographics. And we used receiver operator characteristic curves to look at platelet counts that could predict the acquisition of venous thrombosis. And I'll show this a little bit more in the results, but essentially what you do is you look at the sensitivity, which is essentially patients who do have venous thrombosis who meet a specific platelet cutoff, also known as the true positive rate, as well as 1 minus the specificity, so patients who do not have venous thrombosis and meet the platelet cutoff, also known as the false positive rate. And then you come up with platelet counts or numbers which optimize the sensitivity and specificity, looking at an appropriate trade-off between the true positive and the true negative rate. And using the ROC curves, you look at the area under the curve, which essentially looks at the probability of accurately predicting the acquisition of a venous thrombosis by knowing the platelet count. And in terms of our results, so during the study period, 520 elective splenectomies were completed, of which 344 were done in an open manner and 176 in a laparoscopic manner. The overall incidence of venous thrombosis was 6.7%, and the open incidence was 6.1%, and the laparoscopic was 8%. This is in keeping with a lot of the literature, and there was no statistically significant difference in venous thrombosis incidence, depending on whether the case was done in an open or laparoscopic manner. In terms of patient demographic information by type of surgery and the presence of venous thrombosis, so open surgery had a higher proportion of malignant indications, 66%. That was right here, compared to laparoscopic, which was just 34%. And this was statistically significant. There was no statistically significant difference between type of surgery, indication for surgery, benign or malignant, and incidence of venous thrombosis. And there's also no statistically significant difference in patients who had venous thrombosis based on age or gender. So in terms of the receiver operator characteristic curves, so just to get everybody on the same page, so the sensitivity, as I talked about, is essentially patients who have a venous thrombosis who meet a platelet count, and this is the true positive rate. And the 1 minus specificity is essentially platelets who do not have a venous thrombosis but meet the platelet count, or the false positive rate. This red line here is a line of no discrimination with an area under the curve of 0.5. a perfect test, so that could 100% discriminate or predict the fact that someone has a venous thrombosis, would have an area under the curve of 1, and it essentially would come up along the y-axis and across the x-axis. Anything greater than 0.7 is considered good, and anything greater than 0.8 is considered very good. So in terms of all surgery types, the platelet count was a good predictor of venous thrombosis with an area under the curve of 0.77. Maximizing the sensitivity and specificity, we were able to find that the platelet cutoff was 545. And then using this, the negative predictive value in the all-comers was 97%. When you look at just the open surgeries, again, the area under the curve, the platelets were a very good predictor of venous thrombosis with an area under the curve of 0.7. And in terms of the platelet cutoff that we found, it was 457 was the platelet cutoff where sensitivity and specificity were optimized, representing an appropriate trade-off between the true positive and true negative rate. And again, the negative predictive value was 97%. And when you look at the laparoscopic group there on the right, so in this situation, the platelet count was an excellent predictor of venous thrombosis acquisition with an area under the curve of just of 0.89. And then the platelet count where sensitivity and specificity were maximized, again, looking at an optimal trade-off between the true positive and true negative rate, was 659. So in conclusion, platelet counts are a good predictor of venous thrombosis in both the open cohort, but particularly so in the laparoscopic group. And this is quite timely as the pendulum really has shifted to the splenectomy being completed in a laparoscopic manner with both our evidence and other evidence out there suggesting a higher rate of venous thrombosis. And so we created platelet cutoffs, which can be used to make decisions, and specifically patients with platelets above these cutoffs could be considered either for chemical prophylaxis or for further imaging to document that in fact there is a thrombi, and then to treat them accordingly. And future work should really look at the interaction between platelet counts and the underlying disease biology, which necessitates a splenectomy as they're looking at their interaction and potential drivers of venous thrombosis, and to really look at whether malignancy type, so whether it's a hematologic malignancy, as is often the indication for splenectomy, versus metastatic disease as the driver, and if there's a difference between the two. Thank you.